All right, this is Frank Vocci. I'm at the ASAM meeting at the poster sessions with Dr. Tim Wiegand. And hi, how are you, Tim?
I'm doing good.
Good. And then, would you describe this New York iStop prescription monitoring program for us?
So in August of 2013, New York State rolled out the prescription monitoring program, the iStop program, the internet system for tracking overprescribing. It's a real-time surveillance system, so if I'm writing a prescription for a controlled substance to any patient that's non-emergency, not institutional, and I'm not a veterinarian, some exceptions to this rule. So if I'm writing a prescription for methylphenidate or oxycodone, I have to in real time access the prescription monitoring program, check the last 6 months record, which is just right in front of me, what's included in a prescription monitoring report, and then a unique reference numbers generated from that encounter, and then I can include it in my patient notes for that encounter. Every controlled substance given to a patient in New York, it's mandatory that the prescribers check the iStop program. It's a simple login. It's on our desktop. I access it. It takes me less than a minute to type in the patient name, the date of birth. There's even a mechanism if I've got a clinic full of patients and 15 that I'm seeing, for example, for buprenorphine opioid maintenance, that we can prepare a spreadsheet and access and get a quick report. You can designate other providers, a nurse practitioner, a PA, or a clinic staff, for example, that can be appointed to access the record. They still have to do that essentially in real time when you're writing the prescription to generate the report, but the entire burden is certainly not on the physician. And even I usually access the records myself, but it takes less than 2 minutes to enter, review, and have the report out. Or I can have my PA access ahead of time, and we've got a report generated for the clinic patients. Right now, the physicians don't have to log any prescription information, but there is a reference number, so when I access that the iStop program, that documents that confirms I check that program.
I see.
So on August 27th, the program rolled out, and every time I've written a prescription up until that, basically the abstract deadline for the conference, so it was 162 patients, 162 patient encounters, and we were able to access iStop in every situation but 3. There was one day where I was not able to get onto the web server, so I had to document. And in my practice, I was a little surprised to find out that there's a high concordance of what patients were reporting. I mean, this is a vulnerable addiction population. A lot of them have prescription drug abuse, but the histories that they were providing was correct, and there were 8 situations that were different from what the patient was reporting. And so that my study was looking at what were the differences and what specifically did we find. And so in the population that we studied, there were 8 instances, and 3 of them had been in buprenorphine programs and not disclosed that they had just gotten Suboxone, not in real time, but had actually been discharged from their program. So they weren't receiving it when they came to me, but they had been in sometime in the last 6 months and were discharged. One was for alcohol, another was for cocaine, a third was for suspicion of diversion. It turned out that she had a cocaine dependence problem, and so 3 of them were on buprenorphine, and we've identified that. One was filling methylphenidate despite stimulant abuse, and then others were filling, in one case, clonazepam, and 3 of them were filling pregabalin. So the situations I encountered were previous buprenorphine not reported, and then other prescription medications that were not reported, and in all situations they were abusing the medications. Now, no situation did it lead to immediately discharge from the program, or it actually didn't really influence the treatment outcome in terms of my giving them the prescription. What it did change, though, was the relationship became more therapeutic, and that they understood that I had access to this type of medications, and we used it to adjust monitoring, or I understood how, for example, they'd been working with their provider in the past, what kind of pitfalls there'd been. One of them hadn't disclosed that the degree and severity of the alcohol dependence that they had, and when they had shown up intoxicated and had positive alcohol in the urine screen, they were discharged from a previous program. And so it allowed us to adjust the patient-specific treatment program, whether it's pharmacotherapy, counseling, group, and work with the patient at their level.
I see. So the patients seem impressed with the fact that you know what they've been prescribed in other places then? They
do, and now when I have a patient coming in as part of their intake, I'll turn the computer screen around and say, I'm going to look at your controlled substances record, and we'll type in information, and they can see it confirms that they were just in detox, for example, and they got a prescription for diazepam, and that was their detox prescription, and then buprenorphine, and they can see that, look, this is very accessible and clear. And some of them have said this really helps, because if the emergency physician that was giving me a month prescription in the past knew this or could access this, they could have seen that I was getting this at several other hospitals. And some of them have said, I can see how this is going to be a really useful tool to stop some of the behaviors that was fueling, my addiction. And others have just, accepted that. Some of them a couple of people have been bothered initially, but usually they're struggling with their chemical dependency at that time, the ones that have been bothered.
Okay, all right. Well, what do you see the future of the program? Is it going to keep going with this?
Well, the future of the program will be physicians entering their prescriptions from their end. So right now I access it and review the records, and then the pharmacy will upload the prescription information on their end, but I don't access from my end to the pharmacy. So that will change, electronic prescribing. And I'm hoping that a federal program is mimicking the ISTAP program, because we don't have data from Pennsylvania, we don't have data from Connecticut or New Jersey, and certainly the borders of the state, patients can go back and forth, and there needs to be some collaboration. And there has been some literature on the ideal prescription monitoring program. When one state in close proximity to another has a vastly different program, it just kind of shifts the burden of the problem a little bit to another area. Right. So more transparency, disclosure, and there was a lot of hesitancy in that this is going to add work for physicians. This is really going to be intrusive in my practice, and that's not my experience at all. In fact, I'm medical director of the addiction treatment program, but I also have a consult service at the University of Rochester where we see overdose patients, withdrawal, unintentional overdoses, and I'm not prescribing for that population, but when they come into the hospital, I can pull up the records, and it's really helpful to find out that somebody's getting 8 milligrams of alprazolam, they're getting several doses of pregabalin, 350 milligrams of pregabalin, soma, methylphenidate. I can see this panel and this fingerprint and know an awful lot about that patient. And quite a few patients then that I have that information with, I can contact their providers and say, this person just was overdosed in the hospital. And, there was an unintentional overdose, and there's other drugs involved, alcohol, or, their urine screens has not showing any of the medications that you're prescribing, and so I work with the other physician and decrease morbidity, mortality related to overdose.
That's very nice. I could see where patients who are poor historians would actually benefit from this, because then you'd actually know what they were on even if they couldn't remember.
Right, absolutely. It doesn't give you all of the medications, the non-controlled medications, but for the most dangerous substances, at least in terms of potential death from accidental overdose, that gives us all of the information at our fingertips.
Okay. All right. Thank you very much.
Thank you.